So now macular degeneration, which I'm sure that's what many of you are here for, the number one reason for going blind after age 65, and overall in the whole population, the number two reason. So a very, very important cause of blindness. Now, you heard me talk about macular edema, macular degeneration. What is the macula? So the macula is the area of the central vision. So it's part of the retina. So the macula and retina are same thing. It's just the macula is a certain part of the retina. And that's the area that deals with your central vision right here. Notice how much more retina there is beyond just the macula. All those pictures pretty much hone in on the central vision, the macula, but realize there's all this area around as well. Let's see. Did the same thing for me. Okay. So, our retina is actually made up of multiple different layers, and this is important when we're talking about macular degeneration. So the retina is like the lining. Remember we talked about it like the projection screen that the image gets projected on. That projecting screen has all these different layers as part of it. So there are cells that bring the information to the optic nerve. There are cells that make connections between cells. There are cells that actually respond to light. Those are called those photoreceptors. They are the ones that actually capture the light and start the process. And then there's a layer of cells that take care of the seeing cells. So they transport things back and forth. They metabolize things, break down the waste products, get rid of them, bring in oxygen and other nutrients to the cells. And then this deep layer here is this really, really rich network of blood vessels that just send oxygen in. All they should be sending is oxygen through here, no blood, no fluid, just oxygen. So we have the retina, and those cells that take care of the seeing cells are called the RPE cells, and then these blood vessels underneath it all are choriocapillaris. Don't have to remember the names, don't even worry about that. So when we talk about macular degeneration, most people have what's called the dry type. We're going to see detail about what's the difference between dry and wet, but just know wet means fluid, leakage, bleeding. Dry means there isn't any fluid, there isn't any leaking, there's no bleeding. So in dry macular degeneration, what happens is down at that layer where these helper cells are, those cells that transport and get rid of waste and metabolize, little protein deposits start to build up, like this yellow egg-shaped thing down here. As they develop, what happens is we can see them in the eye. So those little yellow deposits are called drusen. They're kind of a combination of protein, lipids, old cells. They're things that the body should have been getting rid of, but it's building up. So when we do that picture, like the ones you were just seeing, now what we're seeing are little clumps of yellow spots. These little spots are those deposits. Similar to with the early stage of diabetes, in the early stage of the drusen, nobody notices anything. You wouldn't know you have this unless you have an eye exam, until they get to a certain level. As time goes on, some people get more damage. So those drusen in the retina, those deposits, cause the overlying retina to start to deteriorate and thin. And there's a condition called geographic atrophy. So atrophy just means thinning or loss of tissue, and geographic because it kind of looks like a map. So these areas, these large areas of thinning of the retina, occur in the late stages of macular degeneration in people who have the late stage of the dry. So in the early stages getting to this, what will happen is those little deposits cause little blind spots. There may be just little spots of thinning. Maybe someone's reading across a line and 3 of the letters are disappeared, then they move their eye and then they pop back up. They've got these little patches where things are missing. And that's from the damage in little sections to the retina. Eventually those sections can join together, get bigger and bigger, and then you can get a whole big zone where you have a big blind spot. So this person probably wouldn't be able to read very many letters reading the eye chart. They could see your fingers if you hold them up in front of them. They could tell that you're sitting there, but they may not be able to recognize your face because your head would fall right in that blind spot. But remember I was saying how much retina there is beyond just the central? All that peripheral retina is normal with macular degeneration, or at least can see very, very well. So everything out here is still functioning. And it's just this area that almost looks like a cookie cutter. Someone just went with a cookie cutter and took a piece out. That piece where it's missing, that's where they're having the problem. So as we were saying with drusen, you have some minor visual disturbance. Maybe as those drusen get bigger, you may notice a little waviness from this deposit that's sitting in the retina. Things look a little wavy. As that retina starts to thin, we get areas of missing vision. Now, people can go from dry to wet really at any time. You can have a few drusen and get wet. You can have little areas of thinning and then develop the wet form. And we're going to talk about what the wet form looks like. 15 million people in the United States have some form of AMD, and 1.7 million, 2 million people have the advanced form, where they either have that big cookie cutter loss in their central vision, or they have the wet form. So what is the wet form? The wet form is when abnormal blood vessels start growing into the retina. Leading cause of legal blindness over age 65, about 200,000 new cases every year. So once again, going back to our cartoon of the retina, where we have our layers. So these layers down here, this bright red down at the bottom, this is the choroid and that choriocapillaris we were talking about. This should just be sending in oxygen to these seeing cells. But the blood vessels all stay outside the retina. In the case where we have drusen, you can see this yellow deposit sitting in here. And what happens is the retina that's over this deposit is not getting as much oxygen because you've got this stuff blocking it. So oxygen will get through, but not as much. What does it do? That stimulates that same chemical, that growth factor, that blood vessel growth factor we talked about. Now that blood vessels are growing into the retina because they're trying to help, they're trying to bring in oxygen, but they don't belong in the retina. And that's where they start to cause trouble. So the blood vessels grow more and more. They start to leak because they're not normal blood vessels, they're leaky, similar to what we were seeing in diabetes. And then we look in the eye and what do we see? They can hemorrhage because they're not normal. So now there's blood in this person's retina. And they, just like in diabetes, where they bring in their own support structure and fibrous tissue and things to help them grow, they will create a scar in the retina if it's not treated, a big scar that will cover the central vision. So, overall, those are the main two forms, either dry or wet. And now let's talk about what we can do about it. So in the next section, we'll talk about even just evaluating and what things to expect. So in the beginning, those mild vision blurring, distortion from the little drusen. Now if you have distortion or a blind spot that comes on pretty quickly, like you notice it over just a couple of weeks, that's probably not from drusen. Those drusen we saw take years to develop. And actually, underneath the retina, in all the sides, even where you don't see drusen, there's some of that yellow material under there. But it just comes on very slowly over years. If you notice over a few weeks or a month that now your grid that you look at home looks wavy, curtains hanging look wavy, a door jamb, you see a little curve to it, and you didn't see that last week, that's not normal. That could be because there's fluid in the retina. The fluid balloons up the retina like we saw with diabetes, and so that edge of that curvature is giving you the curve that you see in your vision. So that's something to call your doctor about if you see that coming on quickly. It's very, very rare to go completely blind from macular degeneration, and that's something that everybody should hear. It is very rare that you would be in the dark where you can't see anything from macular degeneration. That might happen in someone who has severe hemorrhage. Someone's on a blood thinner for other reasons and they get a severe hemorrhage that bleeds through their whole retina. That is extremely rare, much less than 1 in 1,000 chance. So most people, even in the late stages of macular degeneration, have some peripheral vision that can help them function, but they might not be able to read, see TV, recognize faces, anything with detail. They lose that. That's the hard part about macular degeneration. So here are some examples. Parts of words missing, words looking distorted, a blind spot right at the spot where you're trying to see something. You can see everything around it, but you can't. You're trying to read the title on the bus, but you can see the bus, but you can't see the title on the nameplate. So what are the risk factors? Hereditary is a big one. Probably about 70% of the risk comes from the genes you've inherited. Age, as you get older, it's more common. Caucasian race is higher in the Caucasian race. History of smoking. Smoking will increase the risk of all the risks that we're going to talk about, get doubled, tripled if you're a smoker. Low antioxidant blood level. So your blood doesn't have as many of the things that detoxify. And that's where the vitamins come in and diet. And then hypertension. If you have high blood pressure along with the other things, it makes it worse. So treating your high blood pressure is important. Possible risk factors that are not for sure proven, but there are some associations, is having high sun exposure at a young age, and also having cardiovascular disease, coronary artery disease, having those plaques in your blood vessels. You may be at the same risk of plaques forming basically in your retina. Regarding the genetics, and we're going to hear more about this, I'm just putting one slide in now, but we can actually tell what someone's risk of progressing to that advanced stage is by doing a simple blood test or a cheek swab. There are a certain number of genes that if you inherit a certain form of that gene, you have a higher risk of getting macular degeneration. You can look at that whole panel of all those genes and find out which one you've inherited, and they can add up all that little individual risk from each gene, and the company that produces this test will then be able to send a report that says, okay, over the next 10 years, here's your risk of getting the advanced type. You can see it rising as the person gets older because it is age-related. And this person can now know that their risk of going to the advanced stage is, I think it came out to be, this person was 62%. That's a pretty good risk. This person, when they get this information, they really want to pay attention to everything they can possibly do to help lower that risk. And so this is very useful information to know. Is my risk 2%, 5% in the next 10 years? Or is it more like 60 or 70%? Very powerful information. So, testing. When you go into the eye doctor, in addition to checking your vision, they're going to have you look at a grid, an Amsler grid. And anyone who has macular degeneration should have one of these at home. Put it on your refrigerator, in your bathroom, look at it. You know, some people just get fatigued of doing it, and I tell them, okay, if you don't want to do it every day, look at least once a week. Once a week, you're going to notice the difference. It doesn't take a lot of time. 5 or 10 seconds, really. I don't want you to have to study it. You're going to see this if it's there. You're going to see this distortion where the lines seem to be bending in toward a point. It may not be in the center of the grid. It might be off to the side. I'd rather have it off to the side. That means we can catch it before it gets to your central vision. You have to check one eye at a time. You have to cover one eye and look with the other, because the other eye will fill in the gaps for the first eye if you just look at it with both eyes open. So take 5 or 10 seconds, you're looking at the grid, you try to focus in on the center dot, and then you're trying to see the corners with your side vision. Try to investigate all these different corners with your side vision to make sure all those lines are straight. You may see some little dips and little waves, and that could be from the drusen that you have. If it's about the same every day, no problem. But let's say it's increasing, and in 2 weeks it's double the size of what you saw before. That's not normal. Call and have it checked. That angiogram we were talking about, where we use it for diabetes, we also use the same kind of angiogram for macular degeneration. It can show, so here the dye is going in, you can see the white is the dye once again. All these little speckled dots are those drusen. So the drusen will take up the dye, and we can see them as little speckled spots, but they don't leak. This thing here, this big bright spot that's lighting up, that's not normal. Those are abnormal blood vessels in the retina. These are blood vessels that grew in from that deeper layer we were showing on those pictures, those cartoon pictures. So blood vessels are growing into the retina, kind of like grass growing up through cracks in a sidewalk. And then when they get into the retina, they spread out and enlarge. And that's what you're seeing here, where you see that big spot lighting up. Here's another, zooming in, this big spot. It almost looks like a little broccoli flowerette growing out into the retina, right here. Those abnormal blood vessels can bleed, and so here's an example showing the blood, and the little blood vessel abnormal in the middle of all that. End stage, untreated, becomes a big scar. And then this person is now at that level we were talking about, where they can just kind of see fingers, but they can't see details. the OCT, that test that we were talking about, this is what a normal OCT looks like. So the OCT is a machine like this that you put your chin in, and a light is sent into the eye, bounces off the retina, and comes back to the camera. And depending on how quickly it comes back or other ways of analyzing that, you can detect these different layers. And so a normal retina has a little dip in the center for the central vision. So now what we're doing is we're taking your retina and looking at it on its side. So we're like making a slice. We're turning it on its side. So this back here is the back wall of the eye. This would go all the way around and curve all the way up and curve all the way up on this side. And then this little dip is the actual center of the retina. These green stripes on top are the retina. That's the way it should look. If that layer gets a little bump in it. So this bright layer, those are those healthy cells that take care of the seeing cells, that bright layer. That's what this is here, the barrier between the blood vessels underneath and the normal retina on top. And you can see something's pooching up this layer. Here's another example. This is lifting up and there's fluid and the retina on top of it is swollen because it's leaking. So, what are the things that we have that we can deal with this condition? So A and B nutrition. You're going to hear a lot about nutrition, so I'm not going to spend a lot of time, but remember green leafy vegetables, kale, spinach, broccoli, greens, turnip greens, collard greens, green vegetables. Fish, if you like fish, have fish once or twice a week. UV light protection. So you want to have sunglasses and have the UV coating. When you get your glasses and they ask you, do you want the UV protection? Say yes. You want to protect from things that are going to stimulate oxidation or abnormal chemicals being produced in the retina. UV light protection is important. Now, when you get to the more severe stages where these drusen deposits are larger, that's where the vitamin supplements come in. The vitamin supplements are based on a study that was done over 10 years, 4,700 patients. It wasn't a small study. And they looked at how did the people do if they took these vitamin supplements. They made the supplements out of the idea that if we increase the antioxidants, the things that basically detoxify in the bloodstream, maybe this will slow down the condition. And they were looking to see, can they slow the rate that people lose vision? Can they slow the rate that they go to that advanced stage? The original study had vitamin C and E, beta carotene, and zinc. That was the original study. I'm going to tell you about an update to this. They showed that by taking the supplements overall in a whole population, you can slow that rate to the advanced stage by 25%. Lutein is a protein that's in the retina around your central vision. It filters out blue light. It acts as an antioxidant. And beta carotene in high levels can cause problems for other medical issues for people. So they did another study where they took out the beta carotene and put in lutein. And basically they came in with similar results. So it still had the C, the E, and they added lutein, and zeaxanthin is another one in the in the retina around your central vision, another antioxidant. They added that. They also had an arm of the study where they looked at omega-3s, the fish oils, and they thought, well, if fish is good because of surveys that were done that amongst patients where it seemed like people who had more fish did better, maybe adding omega-3s would help. So what they found is that overall, they had about the same results as the original study. Taking out the beta-carotene and adding in lutein and zeaxanthin still was able to reduce the rate of progression about 25%. Adding the omega-3s didn't seem to make a difference. So it either means that there's something in fish, or the interaction of everything that's in fish helps in a way that if you only take omega-3s, it doesn't give you that same benefit. Or maybe it's something else that people who eat more fish are more healthy, and maybe there's other reasons. But in any case, just the omega-3s alone, adding that didn't really affect the rate of progression. So I just tell my patients, have fish. Now, if you, then what was done, they went back and looked at that study and added in the genetics. This genetics is new information. You know, it was just 10 years ago that we found the first gene that has the ability to increase your risk for macular degeneration. So they went back and looked at the study and looked at the different groups. They had people in the study who took just the antioxidants, the C and the E and the beta carotene. They had some people who took just zinc. They had some people who took all of it together. And then they had some people who took nothing. And they looked at all these different groups and added in the genetics. And so in each of those groups, you could say, okay, someone has this genetic profile, how do they do if they take zinc? You have this genetic profile, how do you do if you take the full vitamin? How do they do if they didn't take anything? And so what they found is that there are some people, some subtypes of macular degeneration where if you take the excess zinc, which is a pretty high amount that's in this vitamin, that you actually do worse than if you hadn't taken it at all. So that was very, very important information. And it's totally accessible now. You can ask your doctor to have that test done called macular risk. And they will tell you what your genetic subtype is. They will actually give you a little report that says what's recommended for you is the standard AREDS formula. What's recommended for you is no zinc, AREDS without zinc, and based on what your genetic profile is. So that's taking that to the next level of what we've learned. Okay, so I have just a few minutes left, but I want to give you the update of like what's new, and I want to answer a couple questions that I always get. So first question is, why can't we just laser this spot? That's what we used to do. Before we learned about that growth factor, that's what we did. We would laser it. We would see the spot that has these blood vessels, and we would laser it, and that would kill the blood vessels. But what happens is you get a permanent blind spot right at that spot where that laser was done. So now you've gone from a blurred spot to a permanent blind spot. At least it won't get bigger, so that was what the consolation was that we would tell our patients is that, well, the spot won't get bigger anymore, we've stopped it, but now it's a permanent dark spot in your vision. So that wasn't a great treatment. Then we went to the next level where there was a dye that was given, and then a low-level laser was given. So the dye actually helped activate the laser energy activated the dye. And so we could use less laser energy. The laser was more focused on the places on the retina that had the dye. So you know how we saw how the dye lights up real bright? Well, if we put the dye in, this is a different dye, and then laser, using a laser that activates the dye to kill the blood vessels, you could do laser more safely and kill the blood vessels. So that was the next step. That was verteporfin, or PDT. And same thing, laser being given to the spot, but it wasn't as intense of a laser. But unfortunately, it still does damage. The laser energy, the dye, it creates a spot in your vision. Not as bad as what we had before, but it still was a spot. And what they did, they had a big study, and then just to simplify that, it just showed that the normal history, if you just left it alone, people lost many, many letters of vision. That's why that's arcing down like this. If you did the laser with the dye, they lost less vision, but they still were losing vision. Okay, so that's where we were up until about 2005, 2006. Then we learned about that growth factor. So the same thing is happening in the retina with diabetes and macular degeneration. It's fascinating. It's fascinating that it's the same chemical that's doing that. So now the current treatment is we inject some of that medicine to block the signal that's telling those blood vessels to grow up through those drusen. We're telling it to stop, stop, stop. When we put the medicine in, it stops the growth of those blood vessels. And for the first time, I'm just going to kind of zoom through these because I want to get to the end of what's new that's coming. For the first time, people actually gained vision. So the first medicine that actually showed people gaining vision who have wet macular degeneration was Avastin. Avastin is a medicine that was given to patients who have cancer. Once again, same chemical sequence. What does a cancer tumor do? It sends out a signal saying, we need more blood vessels. This tumor can't grow larger if it doesn't have blood vessels feeding it. And it's the same chemical signal. So cancer hijacks that system and uses it for its own benefit. And sends out the signal to make the tumor grow bigger by sending in more blood vessels to it. So this medicine was originally designed for cancer, because if you can stop the blood flow to the cancer, you stop the cancer from growing. There was a patient who happened to have cancer and macular degeneration, and they were getting this, and the doctors taking care of them watched their macular degeneration get better, which is something we'd never seen before. So they tried injecting it into the eye, and it worked. That's the miraculous thing, that it worked. It stopped the abnormal blood vessels. So Avastin, here's an example of one of those early patients where you can see the big lump in their retina from the fluid and the leakage, and just over time, injection, 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 you can see it flattening out down here at 15 weeks, what it looked like. Lucentis then came out, which is made by the same company that makes Avastin. They designed a form of Avastin for the eye. So Avastin wasn't really designed for the eye. The company tells you that it really shouldn't be used in the eye. They designed Lucentis for the eye, but they both work. They both work. So Lucentis is just a fragment of the overall molecule that's called Avastin. So it's just a piece of it taken off. The reason they designed it that way is they want most of it to just stay in the eye and to get metabolized quickly when it gets out of the eye. And then here's that diagram showing kind of the usual course. This green line is what was done when we used that light-activated laser. And then this is what happened when they got Lucentis. You can see all these, the average patient gaining vision. So that was the new thing, that people would actually gain vision when they had wet AMD. It's hard though. This person's getting an injection every month to achieve this. What we've learned is that once we get the person stabilized, you can see how there's a gain and then it kind of stabilizes. Once we get them stabilized, we can start to back off on that every month. We can go every 2 months and see if they do well. We can then go every 3 months and see if it stays stable. If it starts to leak again, we may have to back up and say we're going to treat you every 2 months from now because we don't want that fluid to come back. So we know every month works, and that actually works the best, honestly. But that's very difficult. It's difficult for patients, difficult for families. We're always trying to achieve the same vision benefit, but with fewer injections. So we'll try to back off to a level where the vision is staying stable, but not as many injections. And then this is just the OCT study, and this showing Lucentis where there's a swollen retina, then a normal retina. Then what came is Eylea, 2011. It was designed to have an even tighter bind to that chemical growth factor. So goal was that it would work and last longer. In many patients it does, in many patients it's about the same. So Eylea, it gives us another option. Sometimes someone's been on one medicine for a while. This basically is showing you the study where they did the comparison of Eylea versus Lucentis, and showing you all these curves are about the same as far as how many letters they gained over time. Works. So basically all three of these medicines work. Some patients can go a little longer with Eylea. Some patients where the Lucentis seems to be not working anymore, you switch to medicine and the Eylea works a little better. So it just gives us another option. That's what's the benefit. Now, just as a quick aside issue, is that you may hear about people talking about stroke, heart attack. These medicines that we use, when they're given by vein in cancer patients, they found that their rate of stroke went up. Let's say it was about, in the actual studies were about 2%, went up to about 4% risk of having a stroke when you're getting about 100 times more of the medicine in your vein versus what we put in the eye. So everyone has known, because these medicines have that risk, that possibly by giving it to the eye, you might increase the risk of stroke. The studies to prove something like that would need thousands of patients. In smaller studies where maybe there's 1,000 patients, we don't see a big difference. It's not statistically significant. There's not enough difference between the groups to prove it, but there's a theoretical difference. So if I have a patient who just had a stroke or just had a heart attack, I might wait a little bit, maybe wait a few months and not use these medicines, but we really don't know if the risk from giving it to the eye really is that much. It may be a very small risk. And then we talked about the different strategies. Some doctors will treat as needed. They'll stop and let it come back, and when they see it coming back, then they'll start the treatments again. Some doctors will just extend the time, which is what I tend to do. I'll try to extend the time and find that threshold, but then I keep treating it because I don't want it to come back. And then what can be done once the vision is lost? Ask your doctor about low vision. Most cities will have a low vision clinic. It's a place where someone will sit with you for about an hour. Test your vision, test your glasses, make sure they're the right strength. Show you all the different devices that are out there so that you can see if there's something that may help you in a specific thing that you like to do. I think it's very, very, very helpful. You should definitely go, at least go once, see what they have, see what's available. And the last thing is the future. I just want to show you this because you'll probably hear about it. There is a little implantable telescope that is being now available for people who have that big scar in the center. So the telescope basically enlarges everything. So it's like walking around with a binocular on one eye and a normal eye on the other eye. Not everybody can deal with that. It takes some adjustment. It takes a person who has a positive attitude who's willing to make this kind of a change. But this is a little telescope that's put in the same place in the eye where a normal cataract lens would go. So when you get your lens implant for a cataract, instead of having that, you have this little telescope put in. It will magnify what you're looking at so that the letters are bigger than the scar tissue. So the image is bigger, so the scar tissue takes up a spot in that word versus the scar tissue taking up the whole sentence. So it's basically it's like looking through binoculars. So I have seen some patients who do very well with it. I've seen some patients who just don't really like the fact of having two different perspectives when they're walking around. And lastly, I want to just make a quick notice about stem cells. Stem cells are exciting. There's a lot of work going on. The cells are injected into the eye and put under the retina, and the idea is that they will repopulate those areas where it's been lost. But this is early research. And people who are in studies for this right now that are sanctioned, FDA sanctioned studies, these are patients who have very, very poor vision. They've already lost most of their central vision. We're trying to see if it's safe. How long will it last? What's the right dose? How many cells do you have to put in? What are the consequences? What happens 5 years later in someone who's had stem cells put in their eye? You will hear about doctors just doing it right now on their own. There are clinics being set up where you can go in and you pay them $20,000 and they'll put stem cells in your eye. Some of those clinics have been shut down because patients have had detached retinas, scar tissue forming on their retina, blindness. So it's serious. So before you make a decision about something like that, you want to find out a lot of information about what they're doing. To be in a study, you shouldn't have to pay $20,000. You should be a part of a study where they're going to evaluate this. It should be you're being compensated for your time in some way, and you're not paying $20,000 for this treatment. Don't do it yet because you want to see what the actual best option is. Once you have this treatment, you may not be available or eligible for other treatments that are going to come 1 or 2 years from now. So I just wanted to put a plug in about that. The bottom line is, though, as you can see, there is a lot going on. This is probably one of the most actively researched areas in ophthalmology. The future is bright. This is probably the most intense time for these injections. As time goes on, there's going to be combination therapies. There's going to be little pumps and things that will deliver a little bit of medicine every day that we just have to fill it once every 6 months. All of these things are being worked on right now. And so just hang in there, but the future is definitely bright. I enjoyed talking with you.